Yes, the breath is your power. And I started voice therapy in the summer of 2020, which is a notable weird time to be doing anything. And it absolutely changed my life. Essentially what you would imagine if you were constantly just kind of straining to talk. All these muscles are so tight and fatigued that the larynx maybe doesn't want to lift during that swallow, or that esophagus doesn't want to open all the way. And so people have this tight feeling. Some patients, one session, bam, they're done. Other patients, especially singers, they usually take more time.
This is Vocal Talk. We explore how voices are built, cared for, and sustained through conversations with working vocal professionals. No shortcuts, just science, technique, and lived experience. Welcome to Vocal Talk.
Oh, yes. All right, we're back with Vocal Talk. I'm super excited to sit down with Natalia over here. She is a voice, swallow, and upper airway therapist in Louisville, Kentucky. And yes, I'm trying my best to say Louisville. She's also a singer who loves...
Well done.
Thank you. Louisville and whiskey, I've been there. She loves both opera and jazz music. She works as an SLP at a wonderful clinic over there, and also has her kind of Instagram channel where she's doing like a lot of scoping videos from a singer's perspective, from a voice specialist perspective. And so happy to jump on and just talk about a little bit of your experience, a little bit of your journey, and also like what you're interested in and what you're learning and what you think is cool about working with the voice. So hi.
Hello, I'm so pleased to be here. Thank you for having me.
Yeah, this was fun. Your Instagram feed was just like a ton of self-scoping videos. And I was so jealous because I wanted to buy one of those things forever. And it's kind of hard when you're not like, a real doctor.
They are very expensive.
They are pretty expensive.
I feel very, very privileged to be putting something so expensive down my nose.
Did you work with one of like the rigid scopes first before you went flexible?
I actually know I started training on flex, and as weird as it sounds, it's easier to do a flex scope than it is to do a rigid. In my experience, maybe other people will disagree, but I find the flexible scope to be much easier to do on patients.
Yeah, and
you're kind of have to have a magic touch.
Yeah. What we were talking about this a little bit before we jumped on, but you're working with swallow and upper airway, and also some singers. What can you walk me through kind of what your experience is, typical day to day?
So I do see all three. And if there's anybody out there who's a singer and thinking about becoming a voice therapist, that's what I always try to tell people is you will be doing all three at pretty much any voice clinic that you go to. You'll do swallow, upper airway, and voice together. So it's pretty evenly split on our clinic. It does vary clinic to clinic, but it is pretty evenly split. So it's about 1/3 of each. And within the voice component, there's so much more to voice than just singing, of course, as we all know. So in terms of how many of my patients are actually singers, it's maybe about 5% of my caseload. And within that, it's even less than people who are really kind of trained singers, more than just vocational or amateur singers.
Yeah. When you have singers come in, are the kinds of things they're going through particular to singers, or is it often kind of umbrella, like categorical things that are affecting kind of general patients or population? What do you see in terms of how specific their issues are?
So in my trained singers, people who have maybe gone to music school or are professional singers making their living this way, it's pretty common, the things that they see. So it's maybe one or two main diagnoses that we see. And we could go deeper into that if that's something you want to talk about. But I'd say in the vocational singers, the people who I love to sing at church or do karaoke, we do see a much broader spectrum of what their diagnoses are. And a lot of times that's kind of how it comes up that they're singers, is they're dealing with some other vocal problem, maybe not very typical to singers. And so it's affecting their singing voice. And because singing is such a kind of fun thing to do that's so tied to people's identities and personalities, it's something that they do want to work on, even if their problem is maybe not so singing related.
Yeah, that makes sense. I'm curious, I do want to get into some specific stuff. I think that's honestly what we want to get into is what are the things you've learned and what are the things you're excited about, and what are strategies that actually play out beyond kind of the cookie cutter advice for singers. But I think it would be helpful. Can you kind of walk us through a little of your history? I think you went to Illinois, right?
Yeah, University of Illinois, UIUC.
All right. Were you doing operatic? Were you doing classical stuff over there?
So I started as a classical music major. I wanted to be an opera singer. I do not come from a line of musicians at all. In fact, I come from a very long line of doctors. So it was kind of breaking with the mold. And then here I am in the medical setting. So my class caught up with me. But yes, I did start as a singer, and then kind of pretty early on in my undergrad, I began having difficulty with singing myself, and I brushed it off, and it just kept getting worse. I was having difficulty singing my upper register, difficulty warming up. My voice would give out on me. I'd fatigue really easily. And again, I kind of brushed it off until I got to a point where I just couldn't sing anymore. And at that point, I need help. And I was lucky enough to see a wonderful laryngologist in the Chicago area, which is where I'm from. And they diagnosed me with something called muscle tension dysphonia. So if we later on want to get into common diagnoses in singers, that is probably the most common one I see in singers and just in general, because it's such just a big umbrella term kind of diagnosis.
Yeah.
And I started voice therapy in the summer of 2020, which is a notable weird time to be doing anything. And it absolutely changed my life. So I got my voice back. I've gained so much confidence in my own instrument, and I actually feel like I was better than ever. But most of all, I had never knew that something like voice therapy existed, and it changed my life in terms of desired career path. So I added the second major, then did grad school at the Ohio State University, and then did my fellowship, and now I'm here in Louisville.
That's cool. That's a cool little transformation story. I feel like a lot of people, especially singers, they kind of it's such like an identity building thing to be a singer. So then to like find a way to connect that with another interest where they kind of build on each other is super cool. You mentioned the muscle dysphonia thing. Can you break down just a little bit? What is muscle? It's muscle tension dysphonia?
Muscle tension dysphonia. And there's a couple terms that we use for this in clinic. Muscle tension dysphonia or functional dysphonia. And what that refers to is a problem with the voice. So patients can perceive this very, very differently. For some people, it might mean a really, really hoarse voice. For some people, it might be a totally normal voice, but one that fatigues really easily or causes them pain. And when we scope and examine these patients, we might find that their anatomy is beautiful. They might have beautiful, perfectly normal vocal folds. But when they actually go to sing or use their voice, we see kind of strange characteristics of their speech or their singing, wherein they are using oftentimes excessive strain and excessive force in the muscles above the vocal folds. Essentially what you would imagine if you were constantly just kind of straining to talk. And of course, that's just one example because it could present very, very differently in different people. So for me, I was, I guess, lucky enough that I didn't have any sort of muscle tension patterns within my speaking voice. It only became present when I started to sing. So again, a huge variety in what we see in this, but this is by far the most common diagnosis, both because there's such a big spectrum of this. So you could have just very teeny tiny amount of muscle tension that is excessive to the point where it's not normal anymore. And then you could get to the people that cannot speak at all because everything is tight.
Really?
Just so tight in there. Yes.
Terrifying.
It can be very scary, but the lovely thing is it's just so treatable.
Yeah.
So with the right mindset. So the treatment is therapy. So there isn't really a surgery or any kind of procedure that you could do to fix this because again, the tissue, the anatomy is perfectly normal. So our typical course of action is therapy, and it very much depends for people how long it takes. So for some patients, one session, bam, they're done. Other patients, especially singers, they usually take more time. We spend more time kind of developing good habits and trying to figure out, well, what caused this in the first place? Is it overuse of the voice and the voice kind of trying to protect itself from that overuse? And that's why they're straining. Was it an upper respiratory infection? Was it mental stress? It's a very, very common component, especially in my non-singers. Oftentimes it's these little adorable little old ladies who come in, they have no voice at all. And it's often triggered by stress or life trauma. So what we do in therapy, if I'm sensing your next question here.
Totally. I want to know the strategy.
Yeah, we do a lot of strategies, and a lot of it's very typical to what you do in a voice studio to help release excessive straining. So we'll do a lot of semi-occluded vocal tract exercises, maybe singing through a straw, maybe doing the lax vox with the bubbles, doing physical manipulation. of that tissue. They're doing massage, helping balance the airflow versus the resonance, and kind of tapping into that more oral resonance versus like sitting here in the throat all the time where that problem is sitting. And for my singers specifically, we might actually piece out repertoire and kind of find ways that we can make it easier to sing through specific notes or ranges if that's a problem. But a lot of it is actually similar to what you might do in a voice studio, but a little bit on steroids. Without steroids. Right? In a medical studio, we're not giving them steroids. I meant that as an expression.
Yeah, I always, because I've done this myself, just like the experience of feeling like your singing voice is fundamentally different than your speaking voice and having like tension that's associated with that. How do you, is it, when we say therapy, is it, and outside of the manual kind of massage type therapy, what are there like series of exercises that you're going through with them? Is it really kind of responsive to like what you're hearing them do, or is there kind of a set protocol?
A little bit of both. There are set protocols, but they're not very exhaustive. So there might be kind of a overview of what kind of treatments we do. So I have, for example, with the bubbles, if I don't have my straw, but I don't have my straw here. But if I'm doing the bubbles, I do have a set kind of list of exercises that I have patients do that are meant to kind of balance that airflow and that release of all that tension. But from there, we kind of keep playing based on what I'm hearing. And the same thing with exercises through the range on SOVT, semi-occluded vocal tract exercises or otherwise. I am kind of following my ear because that's what you want, right? If it were as simple as just a set list, well, I'd be out of a job and you could just get that from Dr. Google. But I am trying to really hear what my patients need and respond to that. So every is a little bit different.
So that kind of response, that kind of like diagnostic, you're doing some math in your head, maybe not specifically math, but you're doing like some like internal modeling of how do I get them from point A to point B? Yeah. Of letting go of some of these bad practices. How much of that is like diagnostic driven? Like you are recording them, you're doing the Pratt analysis or whatever tools we're using now. How much of that is like data driven, like quantitative versus you're using your ear? And when you're using your ear, how much of your ear is like the musical informed ear versus the SLP like
therapy informed?
Yeah, totally.
I understand. That's a difficult question to answer. The first question is actually somewhat simple. My ear versus the acoustic analysis. We do always do acoustic analysis, but it's meant to more so confirm what my ear hears than to tell me what to hear. In fact, I'm going to be entirely honest. Maybe I shouldn't say this, but I don't love doing the acoustic analysis. I just want to jump right into therapy. I'm like, I have to do all this boring like microphone stuff. Yeah. It does kind of help confirm what we're hearing. And also it's very powerful. Remember that as a speech therapist in a medical setting, I am having to write notes that are sent to insurance, and then insurance kind of dictates, if they're going to pay for this or not, depending on what insurance you have. So I have to justify therapy by giving them numbers, not just, they sound rough. Insurance isn't going to trust me on that, unfortunately. But I will say we do use a tool in our clinic called a pass machine, and it is used to assess aerodynamic data. So we have patients, it's essentially kind of like a mask with a tube that assesses the airflow that a patient is giving during specific speech and singing tasks. Cool. And that one I actually do find somewhat helpful because it gives me a good, again, my ear can hear this, but it's a nice kind of balance to the ear of, or is this someone who's like very much breath holding and a pressed voice? Or are they like leaking a lot of air? And what happens if we put a little bit of pressure on their face and they have to speak into that mask? Does that get better or does that not make any difference? So I do actually enjoy doing the aerodynamic assessment.
How is that different? So say somebody's on the breathier side. How is that different than like the SOVT stuff versus just like applying a bit more pressure? Is it different because they're just maneuvering different because it's like an acoustical?
No, it's the same idea. So the assessment is just, it's an assessment. So it's not actually, I just use my ear to then determine if the patient sounds better or not. And that gives me clues for therapy. So if they put the mask on their face, ideally the voice doesn't change because we want to catch them exactly how they're sounding, so we can analyze their usual state, their usual whatever dysphonic state they have. But oftentimes, because they then have that pressure feedback, the voice does get better. So oftentimes I'll use that kind of as a teaching opportunity in the moment, be like, "Do you notice something about your voice there? Did you notice how it suddenly got clearer, stronger, easier?" And they're like, "Oh wow, yes I did." And then we get a little bit of buy-in for the therapy, and so it's not meant to do that, but it does sometimes do that.
Cool. Yeah. Do you think that like and I'm curious about the upper airway and the swallowing too. I'm curious kind of how much those overlap. What do you see in terms of, do the swallowing mechanics affect the voice? Do the upper airway, like what's the actual crossover there?
Yes, absolutely. And sometimes we will see patients, particularly with those functional problems. So that muscle tension dysphonia, we call functional dysphonia, because it's not from the anatomy, it's kind of from the physiology of how you're using the voice. So that one we will see overlap over all three sections, not always, but often. So often if there is a lot of excessive muscle tension in this region, patients will complain that it's hard to swallow, especially the things that are drier or thicker, like a hamburger becomes harder to swallow because all these muscles are so tight and fatigued that the larynx maybe doesn't want to lift during that swallow, or that esophagus doesn't want to open all the way. And so people have this tight feeling. Similarly, especially since these functional disorders are often linked with anxiety, or anxiety is a contributant to them, sure, patients will have trouble breathing. They feel like their airway is closing up. They'll sometimes get that stridor sound. And so the treatment remains actually very similar across all three of these components. We'll talk about relaxed throat breathing.
You put them in one of those saltwater float pools and just turn off all the lights.
I wish we had that technology.
some lavender candles in the background.
See, when I used to live in Miami, I just tell people spend a day at the ocean, you'll be fine.
Yeah, that works.
It's a little harder in Louisville, Kentucky.
Negative ions. Oh yeah, that's true. Kind of landlocked over there.
I will say on that subject though, I also treat chronic cough and upper airway disorder. Sure. And in Miami, I would have patients tell me that if they spent the day at the beach, or when they used to live on the beach, their cough would get better, because I think there is a little component of the saline we breathe in.
Yes, definitely.
Everything in there feel a little bit more soothed, just a little bit.
And hey, I mean, honest to goodness, it's like when the waves crash in the ocean, that motion of water creates some I know it's negative ions, but I think it's like ionized oxygen, right? Yeah, so it kind of like speeds up the oxygenation process, kills bacteria. That's cool. I like that.
Yeah. And not to mention, it just makes you feel calm and happy. And a calm and happy body always feels better, right? Yeah.
I wonder what that's like.
That's what people always ask me, not to jump in with my own thing. I don't know how these interviews work. Here I am jumping in with my own thing. People always ask me on my Instagram, how are you doing this with this camera down your nose? Like, when I had this, I was crying and it was so terrible. I'm like, because I'm in control of it and I know what's happening to me, so my body's fully calm. And so that's what I try to do with my patients. I try to calm them down before I scope, so the experience isn't like, oh my God, she's going to scope me. It's like, okay, I know what's going to happen. If I feel a little gaggy, I know why. If it feels uncomfortable in my nose, I know why, but that's okay. I'm giving them that sense of control. And so it's such an amazing difference when you see maybe professionals who don't give patients that heads up, and you could tell the patient is nervous, and how much more uncomfortable that scope is for them than the patients who are well informed and calm.
I'm sure it sounds like you're really intentional in terms of like when you have to guide people kind of to a relaxed state just to get them to do the thing that's going to help them, especially if a lot of it's not anatomical, like if they don't have like actual visible issues. When they do have real visible issues, how quickly do you catch that? Is it pretty quick audibly?
It depends, but usually it's a hard question to answer, because usually people come to our clinic because they have an audible problem.
Do they often show up themselves, or are they?
I always hear it because they're already there. Yeah.
Do they often, are they self-electing to come into the clinic, or is it often kind of referral based? Okay.
It is referral based, but every once in a while you get the patient who's like, I don't know why I'm here. But that's very infrequent. Usually the patients are going to their ENT and saying, hey, there's something wrong. And then the ENT sends to us. It's uncommon that it's a doctor forcing someone, or not forcing, but like really pressing someone to go see us if they're not interested. Sometimes it does happen that they're interested in getting help, but they've never heard of voice therapy, or they hear, oh, you're going to speech therapy, and they go, I could speak just fine. It's like always the grumpy people. And they come in and they don't know why they're here, especially for the chronic coughers, because doctors will go, you have a chronic cough, go see a speech therapist. And patients are like, well, what am I doing here? But other than that, usually patients are pretty eager to see us.
I mean, good. I'm sure that makes the experience a little bit better if somebody is willing to participate.
Yes. Yes, I'm lucky too. I work mostly with adults. So same thing there. No parent is hanging over their heads and making them do it.
Yeah. What do you think when somebody walks in, they say they're walking in fresh, they've self-elected, they know they've got something happening, they don't know what it is. Are there some kind of common misconceptions that they have about their own voice or about their own anatomy? Like what do you typically see in terms of like people's self-awareness, in terms of what people generally do have right and what they might not have right?
Usually my singers are pretty well informed more or less as to their anatomy, but I'll get a lot of patients in who are not singers, who are just regular voice users for whatever job they may have, who come in and they might not even know that they have two vocal folds. They might not even really know that they sit on top of the airway. They might not know that they speak on an exhale. So a lot of this is really revelatory for these patients. And I love that you speak on an exhale, because this really kind of opens people's minds sometimes, especially the people who are really kind of tense and pressed.
It's like the breath is part of it.
Yes, the breath is your power. So one thing that I always, and maybe this will be helpful for everybody, but something that I talk about when I do the acoustic measures is I'll tell people what their average frequency is, and that's determined in hertz. And so I'll tell people, like, do you want to guess how quickly your vocal folds are vibrating every second? And usually this blows their mind, because you tell them, like, it's about 200 times a second, or about 100 times a second for average women versus average men, with those calculations there. And that's kind of crazy. Even for singers, just to take that moment to think about it is insane. And then for singers to take that moment to think that when I'm really up high in my upper range, especially soprano land, we might be vibrating up to the thousands of times a second. And that no muscle in the human body can make that happen. It's all so reliant on the breath. Of course, the muscles are still very much involved, but it's not the muscles making the vocal folds vibrate. Nothing can vibrate that fast.
Yeah.
So that's a big revelation for a lot of my patients that just don't know. And, why would they? They don't spend their time thinking about how does my breath work no more than I think about how do I make my hand wave. Whereas maybe you're all just thinking about that all the time.
Yeah. That is really fun.
Yeah.
It's like the higher you sing, the faster it is.
Yes.
And also the smaller it is, kind of, sort of.
The thinner, tauter.
Yeah.
Yeah.
Yeah. Which I love. That was a big revelation for me when not that this is like a strict understanding, and you correct me if I say something that's anatomically incorrect. That's why we're here. But the idea that the voice kind of realistically does thin out if you're moving through higher registers effectively. And so when I started to feel the change between the full inner fold kind of moving and that extra weight versus letting my voice get smaller as it goes higher, where I think a lot of singers really imagine that it's like a muscular thing. Like it's like you have to work out, you have to build up the muscle to sing higher, higher, higher. And they get super obsessive about it, especially when you're dealing with your pop singers and your musical theater singers and people that just they hear the big belts and that's all they want to do. And it's like, oh no, you have to let your voice get smaller, which also means less air. I find it's just having kind and efficient closure with the air that matters for that note is like a healthier way to produce that note than just trying to slam your way around it.
It's a hard thing to let go of. Oftentimes when I talk about, because there's so many ways to talk about it, right? Like chest versus head and mode 1 versus mode 2, all these terms for it. I like to talk let that higher voice just feel a little bit lighter. It might not feel quite as big and booming. Even if it sounds big and booming, it might not feel quite the same in the body. And there's one, you're not wrong on anything you said, but there is a muscle that is kind of a little bit more responsible. As we know, like the cricothyroid is responsible when we go up higher. And something that I've been it's on my mind because I was talking about it with a patient this morning. But I get a lot of singers more vocational singers who come to me after maybe a couple years that they haven't been singing because they've been having a voice problem. And now that they start therapy, they're like, why can't I sing high anymore? I used to be able to sing high all the time. And I kind of have to explain to them that when we're speaking, we're always using that thyroarytenoid muscle that sits within the vocal folds that's responsible for that mode 1, chest voice, whatever we want to call it. We're always using it because we're talking on it. But that cricothyroid doesn't really get used unless we're getting up higher into our range. So if you've taken a long break from singing, even if we think about it on a matter of weeks or months, that muscle kind of forgets what to do, or it might even atrophy a little bit, especially on more of a matter of years. So I really try to hone in on my patients that if you haven't sung for a while, it's okay if that high voice doesn't feel exactly the same. It does need kind of that love and attention. And lack of frustration with it, just because it doesn't immediately do what you wanted to do. I think people always understand that if you stop running for a number of years and try to run again, it's going to be hard to run.
Yeah.
Singing, for whatever reason, people have all these expectations of what their body should be able to do.
Oh, yeah. No, I feel like that's like the story of so many singers' experience of like, you know, when something's not there, why isn't it there? Why can't I get this right now? Especially if they've been out of practice. But then it's like the harder you push, the more you're beating yourself up and everything becomes counterproductive.
It's tough.
Yeah. I'm trying to like, okay, the best way to take care of my voice is to just let it be what it's going to be without forcing it and without trying to be like too.
Can I share something that a patient
Please tell me.
I had a 93-year-old former opera singer back when I was in Florida. She must be like 94, 95 something now. But she was a former opera singer. She was so delightful, and she was coming to see me for therapy. And she once stopped during an exercise and said something I'll never forget. She said, "Oh, I'm making it happen instead of letting it happen." And I was like, that's the wisest thing I've ever heard in my life.
That is rad.
It's so true, right? It's like you just have to let it happen. You have to create the posture. You have to, have the breath, and then just let it happen. But if you keep trying to make it happen, it's just not going to happen. Yeah.
I've been trying to wrap my head around the, is it the Bernoulli, is that how you say it? Bernoulli effect?
Yeah, Bernoulli effect. Uh-huh.
Yeah. And is that kind of in tandem with what we're talking about? It's like things start and then it just kind of continues on its own accord?
Somewhat, yeah. So there's, oh my gosh, don't ask me too many questions because I have teachers who will be disappointed in me. But there is a Bernoulli effect, but there's another component that kind of keeps the vocal folds vibrating. Mm-hmm. Oh gosh, it's like the 2-mass model of phonation. Oh dear.
I've checked that out.
The biomechanics nitty-gritty of it is maybe not very fresh in my mind.
No, I love it's like the 2 energy sources for like where the vibration actually comes from. Although we recently added a third. There's a third source of energy, and it's got the sickest name. It's like oh my goodness, it has the word vortex in it. It's like airway vortex mechanics or something. Ooh. So some of the new analysis, it's like, oh, this actually accounts for like 30%. Don't quote me on that number. I'll have to go actually read it again.
We are making up physics.
but it's a sizable amount of like how the energy actually is transferred to the motion of the folds, where it's like the airway itself kind of creating vortex patterns that elicit the response.
I was trying to remember that there's the Bernoulli effect starts the vibration as far as I remember, but there are other forces that continue. Because as the air passes over, then there's the back pressure. Yeah. Again, I'm not going to speak any more on that.
Sure, we're good. But like the things that gets your voice to start vibrating are not the same things that gets your voice to continue vibrating. I don't know. I love that. I think that's super interesting because that relates to just the feeling of like, don't continually force it, like let your voice happen kind of idea.
There must be engineers listening to this now who are very unhappy.
They're like, it's pronounced Bernoulli. It's like a French dish.
It's Italian, right? So it's like Bernoulli.
Bernoulli.
Now there's Italians listening to this who are upset.
All the opera singers probably have opinions. It's fine. Do you think, okay, what are kind of, say we have somebody listening right now who's not really in the weeds with like super mechanical expressions of things. What are the kind of generic, good practice, just a few, like what are the few principles that are good for vocal health that somebody that's not super deep in the practice can kind of carry with them?
Yeah. I tend to be as kind of general layman terms in my therapy as possible, because like we said, even in the more advanced, years of training in voice, there's so many different words for things. So I try to use the simplest terms. So things that the average person can do: stay well hydrated. All right. The moister the vocal folds are, the better they vibrate. Yeah.
Yeah.
Take good care of your body. If you sleep well and you eat well, your body will repay you for that. It's tough because I'll get patients in where I just think to myself, oh, if you just got a little bit more sleep and maybe, took care of some other lifestyle things, I think you'd feel better in general. And if you feel better, your voice will feel better too. The voice is an instrument inside of your body. So you can't separate that. Take care of your body and your voice will be happier. And then there's kind of two main principles that I focus in on in therapy. If we talk more about like, how do I have a good good vocal technique, let's say in speaking and in singing. And the two main things are consistent breath flow, being powered by a relaxed breath. And here's some more of those layman terms. So we've heard like diaphragmatic breathing or low abdominal breathing or all those terms that we've heard all these years. I like to think of relaxed breathing happening on more horizontal planes. I call it like vertical breathing versus horizontal breathing. Pending for those terms, by the way. And so I think horizontal, relaxed breath that powers your voice. So we're always speaking on that exhale. I love the bubbles for this reason, because you get that visual feedback of what you're doing. And then the other thing is that sensation of resonance. Do I feel my voice like stuck in my throat and I feel all these vibrations happening here? Or am I allowing my voice to project more towards the front of my mouth? And maybe if I held an M on that, I could feel some buzziness there in the mouth. So we're projecting that voice forward, out and away on that breath, rather than letting it kind of stay and crinkle back in the throat all the time.
Yeah.
So that is like the most layman terms. That is the essence of what I do in therapy all the time.
Yeah.
With then exercises to help make that happen.
Love it. And look, like breath. It's so crazy where it's like, you start off, I loved this. Somebody told me this story once where they're like, there's one type of person out there that they can scream all day. They can put their voice through the paces and they never lose their voice and they never have vocal health issues. And what kind of person is that? And I was sitting there, I was like, I don't know. I've met some metal singers that can do some crazy things, but no, they said it's babies. It's like babies just out the gate, because it's an expression of communication, and it's not an over-controlled thing. It's like their intention is to be heard. So it's like when singers start hyper-focusing on too much control, it's kind of like we come out kind of knowing how to make sound, and then we get in our own way and we have to like relearn that, just like, we have to breathe easily.
Yes, because all the time I ask my patients, I kind of almost, this sounds really mean, but I set them up for failure, because I'll say, show me a deep breath. And 9 times out of 10, people will go, with their shoulders, their chest rising, and all this kind of squeeze in their chest and neck. And I say, think about how a baby breathes, like, and their arms around their head in their crib. You see that rise and fall. And you see it in pets too. If you watch a cat or a dog sleep, you'll see all that motion down here. So why is it that as adults we have this weird perception that if you need a deep breath, you need to be able to see it and hear it like that? Babies, they got the right idea.
They do. They got it figured out, I'll tell you. In terms of kind of those general principles too, like I get so stuck on, like there's so many terms in singer world that just like are not interpreted the same way across everyone, and some that are worked into the kind of the pedagogy of singing. And I'm sure one of them is the word support. So I'm sure coming from like an operatic background, and just as much as I like hear it from pop singers and gospel singers, it's like just this one word that some people have figured out, it's about the actual sound that's coming out, versus other people think it's about this like muscular tightness, over-controlled thing. And so, it drives me crazy, because it's all these singers just passing advice to each other that's like 80% chance that advice is going to make your life harder.
Yeah.
Anyway.
It's an abstract noun. I try my best to stay away from them.
Yeah.
I'm sure I am guilty of some, but I try my best to stay away from them. That's also on that subject. That's how I feel about diaphragmatic breathing. That
Sure.
drives me nuts. I don't know why. It's my pet peeve.
Can you explain a little bit? What is that? What does that actually mean? What do people think it means?
Sure.
Why do you think it's an issue?
I think it's that one of those terms like support that's kind of thrown around like, oh, I have to breathe from my diaphragm. But then you ask the average patient, they don't really fully know where their diaphragm is, or if they point to it, they'll point to somewhere like lower down. I'm sorry, this is a podcast. Audio format, Natalia. Audio format.
You're fine. It's video too. We're good.
But the diaphragm is much higher than we think it is. It's kind of in that dome shape, just below the sternum. And so when people say breathe from their diaphragm, I think what they mean is you want to feel the expansion within the abdomen when you breathe. But I think then people start to push that out. And I'll get patients who then start to essentially almost like belly dance, where they're pushing their belly in and out. And like, oh, I'm breathing. But that actually can add more tension, I think, than is necessary. I think tension is a bit of an abstract noun. So I try to be conscious about that word because there are good tension, right? We need amount of tension in a muscle to hold form, and there's bad excessive tension. So shame on me for using that word. But I do think that it could add excessive, inappropriate tension to patients when they're trying to breathe. And so what I try to cue them, I kind of mentioned this a moment ago, is I try to help them visualize that vertical breath where the shoulders and that chest rise versus what I call a more horizontal breath. Where things are expanding as you breathe and contracting as you exhale, it's happening more on that x-axis rather than the y-axis. And so you might feel expansion in your belly, you might feel expansion towards the sides, you might even feel expansion towards your lower back, in your lower ribs. Sometimes, so I do treat also upper airway conditions, particularly in athletes. And we talk about how when you're running for a long time, that breath does start to rise. So you might feel more expansion in your rib cage out this way, but I don't want this kind of rise and fall. So, gosh, I hope that answered your question.
Yeah. And I super hear you on kind of the abstract nouns, abstract word. It's just like, it's almost like we have to use language to describe something that's, that
you can't see.
Physical and audio. Yeah. And it's almost like we just need to find better terminology to talk about the voice, better talk for the better vocal talk. Oh, there it is. Wow.
Oh, wow. Nice.
Wow, tied it all together. So when you're maybe not even patient particular, but what are you excited to work on, or what? So when I talk to people sometimes, there's a difference between what they spend most of their time doing and the thing that's like right at the front of their understanding, the thing that actually like is like the leading source of curiosity for them. What are you excited or curious about in your work?
Two maybe potential answers to your question here, and why don't I just give both? In terms of things that excite me about my work, this might sound strange, especially on the Vocal Talk podcast, but so when I was a singer and when I transitioned to voice therapy, I was like, great, I'm going to help all these singers. And in fact, singers are a small part of what I do, but I found so much love for the swallowing disorders, particularly the patients who have had history of head and neck cancer and are many years out from radiation to this head and neck region. And they have all sorts of swallow and voice problems and sometimes breathing problems as well. So they're essentially a mess. And it's about the worst case scenario of what can happen to your throat. So I love kind of piecing that apart in that medical aspect of it and kind of the nitty gritty kind of disaster that it sometimes is. And then taking the things that the same techniques I would use for a singer and then applying that to those patients and the difference that can make. So in terms of what excites me in my day-to-day work, that's what I love. I love my head and neck cancer patients. And if you had told me that when I started doing this degree, I would have been quite surprised.
What do you typically see? Like, what actually makes their experience so radically different?
So radiation is a terrible thing. I almost used a worse word, but it's a really terrible thing that can happen to your your neck. I mean, it's a wonderful thing in the fact that it cures your cancer in most cases. So incredible that medicine can do this. But we call it kind of a gift that keeps on giving, because unfortunately we see with these patients a lot of tissue change. And this doesn't happen right away. This actually happens many years out from radiation, often 5, 10, 15 years later. So obviously the patients are incredibly happy and that they're still alive and that they don't have cancer, which is obviously an incredible blessing. So I'm not trying to poo-poo radiation. If anybody who's listening needs radiation, please, do what you have to do for your health. But knowing that there are long-term consequences to that. So the tissue becomes fibrotic, is the term that we use, becomes really stiff. And the muscles don't move like they used to be because they're just so stiff. You'll touch these patients' necks and it's like touching a rock. So naturally, the things that need to happen, that kind of gentle, small manipulations of the muscles, just can't anymore. So they have major difficulty with swallowing. Of course, this is a spectrum, of course. So some people have very little difficulty. Other people have major difficulty swallowing, major difficulty maintaining a clear voice. But I've had a couple of patients that I've been able to make a real difference with just kind of therapy and doing manipulation. And they might never get a normal voice or a normal swallow, but oftentimes these patients are just grateful to be alive because they've been through so much. So they're grateful for any help that they could get. So it's really, it's right now, at least it's where my heart is. I feel such passion for this.
That's cool.
This group of patients.
Do you kind of have, when you're working with people, especially somebody going like, more extreme cases, do you kind of carry like a mental model of what is happening in here on a muscular level? Or is it more like feel and figure out?
I think it's a bit of feel and figure out. And what I'll say to that is when we're doing the laryngeal manipulation, it's surprising somewhat what patients feel, because you'll touch a neck and maybe it doesn't feel all that stiff or all that physically tight. But the patient will react very intensely to it. It'll be like, oh, that's really, really tender. And you're like, okay, it doesn't even feel that bad. So it is very patient-led. What feels like pain to one person might not at all to another person. So it's hard for me to determine how a patient feels. And I try to remind myself that all the time, especially with the more functional dysphonias where their voice might be totally normal, but they feel a lot of pain and discomfort or lack of endurance, is I'm not in their bodies feeling what they're feeling. So I try my best to have the therapy be patient-led, that try to match them at their level and see what they need, instead of me trying to dictate, oh, based on this diagnosis, you're going to need this.
Yeah. Yeah. I'm sure that requires like a certain sense of like empathetic creativity,
just that term.
Yeah. More nouns, more abstract nouns.
But it's a beautiful abstract noun. I'm going to pass.
Well, thinking about, the voice is such like a wide encompassing topic. Thinking about the less extreme cases, thinking about like your daily voice user, what are the kinds of things that you would say somebody from their own viewpoint can pay attention to and how their voice is operating to maybe be more mindful or to keep them on a more vocally healthy path? I mean, we talked about the breath principle. I love that. Can somebody kind of self-moderate their feelings of that muscle tension or dysphonia? Or,
absolutely. Most of the time,
how would you steer
feel that? Because it feels like discomfort. And it feels like, and most, especially singers, will just come in and say something doesn't feel right.
Yeah.
I could tell that I'm struggling with certain passages, or oftentimes there is an associated amount of, maybe pain is too strong a word, though some patients do feel pain, but at least some level of discomfort. So absolutely patients can be monitoring that. And something that I, maybe to this point, maybe a little bit off topic, but I really try to encourage patients, because the voice is something, as singers specifically, because the voice is not something you could readily see, is to have a baseline endoscopy done. Baseline laryngoscopy. And I don't know if this is something maybe you've touched on with another guest or... No,
not too much. Tell us. Can you just tell us what that is?
I feel passionate about this.
It's a big fancy word.
Yes. It's not abstract, I promise. There's a meaning to it.
Tell me.
So this is something we're really trying to push for university level singers. And actually there's a lot of colleges that have voice programs that do implement this. But the idea here is I do consider singers to be vocal athletes. Most athletes have a good sense of their body because most of the time you could see it. So if they have a problem like a broken leg or a bruise, they can see that and know what their baseline was. With singers, it's a little bit tougher because we don't know what our vocal folds look like, because most of us haven't seen it until we get injured. And I think that's something that's really sad, is that most singers will not see their vocal folds until there's a problem. And then it's difficult to determine, what part of this tissue swelling, what part of what I'm looking at is your normal, and what part is because of whatever issue you're going through. So what we encourage singers to do is to come into their local voice clinic. We're very friendly and we welcome you, and ask for a baseline or a healthy scope, where we'll just put that camera down your nose and just, when you're feeling healthy, have you sing a little bit and look at your function and the tissue. And sometimes the amazing discovery that we make is that singers will come in and they're feeling great. They feel like their voice is normal, and they might have teeny tiny little nodules on their vocal fold.
Oh, interesting.
And it's just, hate to say it, but just part of their anatomy. And again, ideally, we all have nice, straight vocal fold edges and all that tissue is healthy. But there are a lot of singers who have little changes like this, maybe little cysts or little baby nodules or polyps. Typically polyps not because they're less chronic, they're more acute, but they might have little swelling on their vocal folds that they feel totally normal about and doesn't bother them. And I've had singers who have gone through therapy and sound fantastic. They feel healthy. Their voice does what they have to do, and they still have little tiny baby nodules or little cyst on their vocal folds. And that's just what it is. So then if that patient then end up having a problem and they go into the clinic, they already know that this is what their baseline looks like, and they don't have to worry about that tissue change if that's what their normal is. So
that's cool. And the whole point is see what it looks like when it feels good.
Yeah, because you are the best judge of what feels normal to you, because you're the one feeling your voice and knowing what it can and cannot do. So for my high caliber singers, they know, can I sing up high and soft? That's usually the biggest test of are your vocal folds healthy? Can I sing high and soft? Can I sing low? Can I belt? Can I do everything that I need my voice to do? And if you can, again, you're the best judge of that.
Yeah. Yeah. Cool. I think that makes sense. Yeah. It's almost like mindfulness is a part of being healthy.
Yeah.
Crazy. In terms of, now, obviously we can do the whole disclaimer, your opinions shared here are your own, and they don't represent the establishment you're working with. All of that, we're going to say, yes, that's true. Are there any kind of standard practices from an SLP side that maybe you don't feel are the most responsible, or is the playbook pretty unified and generally agreed on? I'm wondering kind of in the world of practitioners, I'm sure that there's a core of agreed upon things, but I'm also pretty sure that there's some edges where people might disagree on practices. Can you walk me through a little bit of where those edges might be, and maybe what your feelings on them are?
There's one main one that jumps to mind immediately. And I think most very specialized voice therapists, so when we say SLP, there's so much that goes into that. You get the people who are working with children in schools and the people who are working in hospitals with cognition. So there's a wide spectrum of SLPs. But if we're thinking about the voice SLPs, I'd say there's more and more consensus in this as we go, as the years pass and there's more research about this. But a big shift that is happening that is still a little bit not uniform is about vocal rest. When we should be using it, and if so, for how long. So at our clinic, I'm just going to silence my phone really quickly. I thought I did. At our clinic, we rarely prescribe complete vocal rest. We prescribe complete vocal rest in cases of an acute hemorrhage to the vocal folds or after surgery. Okay. Otherwise, we want you to talk, oftentimes with caveats, big caveats on that. But we don't want people to stop using their voices. And this is a big paradigm shift in general for speech therapy and voice therapy and ENTs. Because in the past, any sort of problem, you're like, okay, well, rest your voice. Stop talking and it'll get better. And actually, you find that when people stop talking and using their voice, there's a bit of, what's the word I'm looking for? Not atrophy.
Like atrophy? Not atrophy.
Atrophy is too strong a word.
A lack of flexibility.
Yeah, sure. It'll come to me in a moment.
Great.
But we see that starts to happen. But more than that, vibration is very important for healing. So if you're just leaving that tissue to sit there, then it's not getting blood flow to it. So athletes know that if they have a muscle problem, they'll use one of those massage guns into their muscle and their muscle feels better. So why wouldn't we want to do that for our voice? We have a built-in vibration that happens every time we speak. So as long as we're speaking with certain, again, there are big caveats to this, because when we get patients who are like super throaty or who are screaming or who are overusing their voice, I'm going to say, okay, we want to monitor how much we're using our voice. We want to voice bank. We want to make sure it's coming out in that most healthy way. But in most cases, we don't want you to stop using your voice completely. So that's a big shift, and I think that is still somewhat debated. I think less so now, but there are still ENTs that I sometimes get patients from who are telling their patients to stop talking.
Yeah. So
no, please start talking again.
When you're telling people, let's, continue using your voice, but with caveats, what are those caveats?
So the caveats are kind of like I mentioned, we're not overusing the voice. So I talk a lot about voice banking. And the idea here is that there are certain things that we have to use our voice for day to day. Most people have to use their voice for work. And if they aren't able to use their voice for work, they might lose money or they might lose their job. So I understand that that is a necessary voice use, although maybe sometimes there are modifications. And you might have to use your voice for safety reasons, for just general communication. And so those things, that's going to be kind of banked in. You're going to be using your voice for that. And then whatever kind of supplemental voice use, like maybe you're not going to go out to that party if you've got nodules right now and we need to let those heal. You're not going to go to that party. You're not going to scream at that baseball game. And you're going to avoid those big belty songs for now until we slowly start reintroducing that stuff in a healthy manner. So that's a big caveat. And then again, sometimes if we hear patients who are actively like doing things that we could hear are harming their voice because of the way they are speaking, we'll try to, in that first therapy session, give them some tools like that. Again, breath flow and resonance, those big two things, to help that voice come out a little bit healthier so they're not aggravating their problem by using their voice.
Yeah. The vocal rest thing is so interesting. Because I went through that process too of like, oh, you got a little polyp. Oh, we need to hit it with some little steroids. And now we need to be quiet for 2 weeks. And I did it and then went back in and the polyp was still there. And then, you know what? You got to go on vocal rest again for 2 more weeks. Here's some more steroids. And then polyp is still there. Okay. Then I think I got a second opinion at some point. And it wasn't even from like a voice specialized SLP. It was just from like a general practitioner. And they looked and they said, oh, you have some cobblestoning in your airway. You might have some acid reflux issues. How often are you drinking coffee in the day? How late do you eat before bed? And I was like, well, I kind of drink coffee all day because I'm a psycho. And also like I'll eat a big bowl of ravioli before bed. We're coming back to the Italian. But all of a sudden, as soon as I changed a few like just life habits, the acid reflux, not necessarily, like we can't know what's causative necessarily in my body, but at the same time, it was like, oh, like these life habits affected so much more than the vocal rest did.
Yeah.
And
oftentimes for our polyps, some of that can go away, first of all, just with time, but also we'll literally prescribe SOVTEs.
Yep.
That help get that nice, healthy, efficient vibration because the vibration is healthy. We want that nice, periodic, healthy vibration to help that blood come in there and help heal you.
Yeah.
There was one more thing I was going to say on the subject, but it left me.
Sorry. If it comes back. If you had a mandate for voice users out there, you could say, all right, from now on, all voice users are doing this. Here's the one thing that would help everybody. What would it be?
I immediately want to say so many things. Weirdly, all the things are take care of your body. Like get enough sleep, eat healthy, drink water, things to keep be careful about your like mental health. If you're feeling like they're constantly stressed, that's going to have its effect on your voice. So find ways to manage stress. So just things to take care of your body and your voice will be happy.
Yeah. Lovely. It's good.
Heck no, I want to add one more. I'm tired. You said one mandate. I'm like 5 mandates. I'm very demanding, clearly.
She's a tyrant.
That's right. My patients would all say that. But one thing that I like to tell singers that they forget about, singers usually have especially if they're trained, they usually have pretty good technique in their singing voice. And then their talking voices are sometimes atrocious. And you talk way more than you sing. And so I want to say, don't forget about your speaking voice. That's the thing. Don't be like constantly frying or talking like super loud all the time. Sorry, I blew up people's ears if they're listening on. Oh, sorry. But try to be mindful of that same good technique you would have while singing, that breath flow, that resonance while you're speaking.
Yeah. Yeah. That is so the truth. Like even the best singers in the world, even people who are touring and doing all this stuff, they're speaking like 90% of their use of their voice. Like, so it's like, you gotta talk healthy. As I say that kind of vocal fry into the mic, you gotta talk real healthy. What do you think about vocal fry? Is it a thing?
But I mean, it's certainly a thing. We could hear it. But is it a thing, like bad thing sort of thing?
Is it a negative thing? Yeah. What do you think?
So I tell my patients it's not inherently damaging. So you talking glottal fry is not going to like give you a polyp. But I will say when people are so used to talking vocal fry that they don't have an alternative. And so then they start to like want to be loud from a glottal fry, or they want to sing and they're so used to that glottal fry, then we can have problems. So let the glottal fry just be a choice. You know, if you need to do voice acting, or if you want to like really like express that you're tired, or if, you know, for like with jazz, sometimes I'll do a little bit of a growl here and there, you know, you have that option. It's similar to a little bit of that aperiodic motion, but don't let it dictate your life, because then I think you will run into problems. But again, it's not inherently damaging with, again, those caveats.
Half of the day, I've got like a little girl asleep in the other room, so I'm always so close on the mic trying to, but I agree with you. Just being mindful of the way we speak and mindful of like bodily health as a whole. I think that's great. I appreciate you sitting down with me for a little time. This was fun. I learned some stuff. If people want to find more about you online, where would it be?
It's pretty easy. You just type in voice with Natalia. There's little underscores between that, and you will find me on Instagram. You'll find me on Facebook. You'll find me on YouTube. And if you're in Louisville, Kentucky, you'll find me in Louisville, Kentucky.
Yeah, come and get scoped.
I'm around. Louisville. Yes, come get scoped. Come to our clinic. It's a jolly good time.
All right. Well, thank you, Natalia. It's been fun.
Thank you so much for having me. I really appreciate it.
Thanks for listening to Vocal Talk. If you found this conversation valuable, be sure to follow the show and share it with others in the vocal community.